leave feedback and be sure to fill out the session and event surveys on this event. Also, if you'd like to know more about Rock from the Heart, check out the website, rockfromtheheart.org. All right, our next speaker was named 2021's Top Doctor Rising by Minneapolis-St. Paul Magazine. Please welcome Dr. Robert Steffen.
Good afternoon, and thank you very much to the organizing committee for giving me the invite. I really appreciate it. So, I'm really the guy nobody wants to hear from. You've met with your cardiologist. They've told you you can't survey this anymore. The imaging has gotten worse or it's severe. You've met with Dr. Garcia. He's taken a look at all of his transcatheter options through the groin, through the shoulder, through the neck, and he thinks that there's nothing that he can do for you. So they send you to me. So I talked to Amy earlier, and she said there were a couple things that she thought were questions that were pretty typical, so I went over I'll go over those, and if you guys have anything else you want to hear about, please feel free to let me know. There we go. So, 4 major topics I'll talk about this afternoon. What does recovery from open heart surgery mean? When people hear open heart surgery, they think of just a really big undertaking. So I'll go into a little bit more of the specifics of what it looks like to recover from open heart surgery. When is valve repair an option? When we can't repair the valve and we have to replace the valve, what options do we have to replace it? And then if we're going to replace the valve, what valve should we use? Okay, so probably the most 2 common questions I get when I tell people they're going to have surgery is, are you going to break the ribs? And is this going to be really painful? And the answer to both of those questions is no. First, I'll talk about the incision. We don't almost ever break any ribs. There's a bone that goes, is it the green button here that we're supposed to hit? Green button, okay. Can you go back 1 slide? Sorry. There we go. So there's a bone that runs down the middle of your chest called the sternum, and so the ribs come from each side and they attach on that bone. So we usually cut either the entire bone on the left, which is called it's called the sternum. That's the bone, the sternum. So we either cut the entire bone, we'll cut part of the bone, or sometimes we leave that alone and we'll do what's called a thoracotomy. So we'll go between the ribs, but we never break any ribs, which is actually important because all the neurons and the sensors come from your spine all the way around the side, and they run right on the ribs. So breaking ribs is very painful. The sternum, which is a rigid structure as far away from those nerves as you can possibly get, actually isn't very painful. So we cut it, we put it back together. It's not mobile, so you don't really feel it going around like if you've ever had abdominal surgery. The muscles move, it pulls on the sutures, that hurts. The sternum is fixed, it's poorly innervated, and really does not hurt very much. So do we break the ribs? No. Is this going to be really painful? No. Is it going to wipe you out for a while? You're going to be pretty tired? Yes. But not going to break the ribs, not going to be super painful. So everybody needs their guy. Santiago got Mick Jagger. He did great. But you can also do great with open heart surgery. So that's Arnold Schwarzenegger on the right. He's had it a couple times. Has done really well. The guy on the left, maybe not as comfortable as the guy 15 minutes after his TAVR, but this may be the next day, 2 days, 3 days after surgery. People are usually pretty comfortable. They're awake. Interacting with their family. Typically, for most of our cases, you're home in 4 or 5 days. So Lastly, what are the risks and the benefits? So benefits, almost certainly you have symptoms. Aortic disease, a little bit different, but we'll talk just about valve disease. So typically you have symptoms. You're short of breath, you're lightheaded, you're dizzy, you're passing out. So the benefit is, one, symptoms. Two, with valve disease, your heart's working harder than it has to work. That valve isn't opening well, and so your heart's pumping harder, or that valve is leaking and blood's coming the wrong way, and your heart's having to pump 120, 130, 140% of the blood that it normally has to pump. So there's a lot of good benefits from it. What are the risks? Cardiac surgery today, in general, on otherwise healthy people is pretty safe. So I quote most of my patients around a 1% risk of death. Stroke, heart attack, kidney dysfunction, usually double to triple that. So if you're otherwise healthy, there's a 96, 97, 98% chance that you're going to have a really good result. So that's the general, what does it mean when someone says you need, should at least consider heart surgery. That's what, in general, it encompasses. Second, can the valve be repaired? So this is a picture, it's a surgical picture of a patient with an aortic valve. It's called a valve-sparing root. So her aorta was diseased, the valve was okay. So that's what a normal aortic valve looks like. So this valve was able to be repaired because where it was living wasn't healthy. So the aorta got big, it stretched it out. The amount of aortic valve tissue was not enough for the valve itself. So shrink that area back down so that the amount of valve tissue is enough for that area, you can repair it. This is what that patient's CAT scan looked like before. So we looked at the aortic root last time. The aorta is big. So if your valve isn't working because your aorta is big, there's a chance we can repair your valve. Now, most of the patient's valves that we operate on look more like this. So this is aortic stenosis. This is the most common mode that these degenerate, and 3 different pictures of them. This is not repairable. These leaflets are stiff. They don't open well. They're full of, those are calcium deposits. There's nothing we can do surgically to make these leaflets open and close again, to make it look like that first one. So when we see this, and we'll know preoperatively based on the echo, if you have significant stenosis, it's almost never repairable. Okay, so we can't repair it. What are the options to replace it? So there's 2 options. One is a biologic, tissue, all sorts of names, but it's a non-mechanical valve. So it's made out of living tissue. So this is a common one we use. It's an Edwards valve. It's made out of the lining of a cow's heart. So it's not actually the cow's valve. It's the cow's, what's called pericardium, and it's treated and it's hand sewn onto these struts to make an aortic valve. It looks almost identical to the function of a normal aortic valve. There are 3 leaflets. When it contracts, you can see that second or third picture in, it opens widely so that blood can be pumped out. And then when the heart stops contracting, it closes. So this is a very common, what we consider tissue valve that we use. The other option is a mechanical valve. So I tell people these theoretically last forever. There's a 1 to 2% risk a year of having an issue, but they don't degenerate over time. Those tissue valves, as Dr. Garcia said, they can fail in a similar way to your native valve. Those leaflets don't open as well or don't close as well. And unlike your native valve, which probably got you 50, 60, 70 years before it started wearing out, those tissue valves, depending on a few factors which we'll talk about, are in the more 10, 12 to 15 years. So, okay, you find out that your aortic valve is diseased and you're 40, you're otherwise healthy, you're active, you have a long life left ahead of you. we may consider putting a mechanical valve in. That's not going to generate over time. You only need theoretically a one and done operation. So these are just a couple of different kinds that we use. There are multiple different really good mechanical valves. So this is a different mechanism, as you can see. It's discs. So the heart opens, the discs open. The heart beats, discs open. Heart stops beating, the discs close. The one caveat to this, and why we don't use them all the time, is you have to be on a blood thinner. And right now, in 2022, you have to be on Coumadin. Coumadin is it's the most common blood thinner that's been used for a long time. Its effect is somewhat affected by what your diet is. So you have to change your diet a little bit. If you want to stop it, it takes a little bit to reverse. If you want to start it again, it takes a little bit to reverse. So it's a little bit of a hassle. So most people don't want to deal with this if they don't have to. There are trials to drop your Coumadin dose. There are trials to use non-Coumadin blood thinners. So that may be something. 5 years from now, we may be saying something very different. But today, that's the answer. So which valve should I choose? There are 50 people in here. Everybody has different risk factors, goals for what they want. So for everybody, it might be different. But what information can I tell you to help you make the best decision for you? And the thing I'll say before I go into it anymore is most people, I tell them they can't make a wrong decision. If you pick a mechanical valve, and you have issues down the road, you made the best choice that you thought. If you pick a tissue valve and you end up having to have it replaced in 6 to 8 years, we don't know what each individual is going to do with that individual valve. We can just tell you in broad strokes what these things look like. So this is probably the best study on one type of valve, the cow valve that I showed you, and this is one institution's experience with that valve. So this is people that received the Edwards Paramount valve at 20 years out. So the top line, or the one on the top on the left, is people who are alive alive without needing a new valve. That second one is died with their original valve in, and that small green line on the right is needed a reoperative heart surgery to swap the valve out. And you can see that the number of people that needed their valve swapped out because it wore out is very low. 5, 6, 7%. Now, there are a lot of factors that at 20 years. There are a lot of factors that go into it. Maybe they were too old, didn't want it, things like that. But in general, of all these people at the Cleveland Clinic that got Paramount valves, a very small percentage at 20 years ended up needing a redo. So what factors, that's everybody, so what factors affect how long your valve is going to last? So here's your risk of needing a new valve at 20 years. So if you're 40 and you need a new tissue valve, your chance of needing a new valve in the next 20 years is pretty high. That's 11, 12%. If you're 70, 80, 90, your chance of needing a new valve at 20 years is very low, 2, 3, 4%. So at 70, almost all we're putting in is tissue valves. In their 60s, if you're already on Coumadin for something, we'll put one in, but again, most people are choosing tissue valves. In the 40s and 50s, we're putting in more mechanicals. So one last topic, and this is not the aortic valve, but it's the mitral valve, and there's similar principles that we talked about. So as you can see, there's that one piece. It's the posterior leaflet of the mitral valve, and it's flailing. It's moving up and down, and there's one small piece that's flailing. And that's what we consider motion. So if you have flailing things like that, that's another reason that we may be able to fix it. And I'll show you some pictures to explain. So this is the mitral valve, the top and the bottom, 2 leaflets. That bottom is moving too well. So if it's moving too well, there are some things we can do. So one thing we can do is take out some of the tissue. So if you have too much tissue that's billowing, if we take out some of that tissue, less tissue will be there to billow, it won't leak. Another thing we could do is, each mitral valve has normal, what are called cords that attach the valve to the heart itself. If those valves aren't working too well, if they're getting long, if that's what's causing some of the valve to move too much, we can oftentimes fix that. So, just in summary, there are multiple approaches to surgically treat valve disease: full sternotomies, partial sternotomies, incisions through the side of the chest. Open surgery is safe and effective for valve disease. Durable options exist for valve replacement. And when we see valves that we can repair, we do our best to repair them. Thank you. I'd be happy to answer any questions if you have any. Great. Thank you.